say a big hello and thanks to Dr. Glenn Bigsby for joining us to talk about Parp inhibitors, which is certainly something that can cause all of us, our heads to hurt a little bit because it seems fairly complex and hard to understand, and I'm hoping to get a little clarity on that. And I also wanted to say, you know, the way that Coca knows Dr. Bigsby is because of his, as soon as he moved back into town, he's originally a Coloradan, but as soon as he moved back into town, one of his first stops was at Coca because it was important to him to connect with us and support our work. And we've felt that, that support nonstop since he's been here. So I just want to say thank you so much, Dr. Bigsby, for being you and caring so much about the women who are battling this terrible disease and providing comfort and healing. So I know you're on sabbatical this year, but we look forward to you getting revitalized and joining us back in the fray shortly.
Well, thank you. Can everybody hear me? Little wave of hands. Everybody good? Well, thanks for having me. I think some of you are here to learn a little bit about Parps. Some people are here to see if I'm actually alive, as I quit practice a couple of months ago and just taking some time off. And so I am alive and doing well, and just glad to spend some time with you today talking about Parp inhibitors. And so I'm going to share my screen so you guys can see all my slides. And what I'll do is I'll just go through all these, and then at the end we can do questions, and I'd be happy to answer any questions and things. So let's see if this all works. I'm not a professional Zoomer, so bear with me. Here we go. And all right, can everybody see that? All right. So my wife's here coaching me too. She does way more Zoom than I do. So kudos to her to help me through this. But we're going to talk about Parp inhibitors today, which is kind of the new latest and greatest in ovarian cancer. It's actually been around for a while. It's been really approved for almost 6 years now. But we have multiple new approvals and new studies and new ways to look at Parp inhibitors, and we oftentimes get a little bit confused about all the literature and things. And so I'll just slide through these here. So that's me. And so, you know, in general, when we talk about speaking engagements and things, we always, as physicians, do we have any conflict of interest? I don't actually work for any of these companies here. They actually all make Parp inhibitors. But I have been on advisory boards. What those are is just a bunch of us across the United States on these boards, and these companies want to know, you know, how we're utilizing the Parps, what we think of the literature, what we think moving forward and things. So it's often just getting some information from us as practitioners and things. So I don't work for any of these companies, but I do give my 2 cents at times when they certainly ask it. So a little bit about me. I was actually born in Des Moines, Iowa. So I'm somewhat of a Midwestern. Most of my family's still in the Des Moines, Iowa area, but my father was a family practitioner in Pagosa Springs, Colorado. We moved from Iowa, and it was a small town family practice. And in fact, the rep for Caris, which is a company, some of you may know that, it studies our tumors. And there's many other companies similar to it, foundations, Tempest, things like that. But the rep for Caris at the time said, when he first came to my office, he said, "I know your name somewhere." And so he actually used to be a drug rep, and he sold inhalers in the years before, and he came by my dad's office frequently when I was in high school. So quite interesting, circling back around, he was a rep for my dad and then a rep for me. He has since moved on to something else, but so I graduated from Pagosa Springs High School. I went to the University of Colorado in Boulder. I got a psychology degree. Only reason I got a psychology degree is I was in my middle of my junior year, and I'd switched my major a million times, and I went to my advisor and I said, well, hey, I need to get out of here in 4 years, so tell me what I can do. And he said, well, this can go for this and this can go for this, and you can graduate in 4 years in psychology. And so I said, that's my major. So I graduated in 4 years. So and then I went to Des Moines University for my medical school, which is back where my family was from. I'm from 5 generations of physicians consecutively. And I don't know if you guys know much about osteopathic medicine, but it's been around for quite a long time, and I have the longest family history in osteopathic medicine. My great-great-grandfather, who takes my middle name, which is Edgar, graduated in the 3rd class of osteopathic physicians in 1895. And we've consecutively been in osteopathic medicine since that time. In fact, my sister was an OB/GYN who graduated 100 years ago in 1895 and is practicing OB/GYN in Lewiston, Idaho, and lives in northern Idaho. So, and I practiced actually with her for 5 years. I actually did my residency. I went into OB/GYN, practiced with my little sister, but had too much of a love for oncology, and so I went back and did a fellowship. Practiced where I was trained for about 8 years, and then came back home to where I call home, even though I was born in Iowa. I really grew up here in Colorado. So just a little bit about me. Here's my family. So these are my little ones. This is Ben and this is Wes. Here's my beautiful wife. I have an older daughter. And this is her with my wife, and I have an older son who is about to graduate from Montana State University. He's got just one more semester after this one. My daughter actually just graduated from University of Colorado in Denver just this last May. And this is my wife and I, and then this is my son and daughter. This is actually we went to the Society of Gynecologic Oncology meeting in Hawaii a couple years ago. And so my older kids came over. We had just had this little one, so my wife wasn't able to go. And so this is my wife and I up here on a backpack trip, which we love to do. So this is what I'm enjoying right now. It's been just fantastic, and just very proud of my family. Let's see here. All right, so let's get into PARP inhibitors. So this is just some objectives. We're going to review PARP mechanisms of action. How does it work? Definitions and terms used in PARP inhibitor use. This is where everybody gets confused. There's so much terminology in PARP inhibitors that it often gets confusing, and so we'll go over all those. We'll go over the indications for PARP inhibitors, and mostly we'll really be looking at the newest indication is really upfront treatment and treating very early with PARP inhibitors. And we'll minimally touch the recurrent setting as most people are getting PARP inhibitors up front these days. But we'll touch on that a little bit. We'll touch about side effects, which are very common, and a lot of people go through them. Again, the basic review of studies, and then any questions. So how do PARP work? What is PARP? So there's the big word, poly-ADP ribose polymerase enzyme. That's really what it stands for. Much easier to say PARP because PARP tends to invest very well. It plays an important role in DNA damage and repair and stability of cells. It is critical for recruitment of DNA repair proteins. It essentially is an enzyme, and it inhibits DNA repair and causes apoptosis, which is essentially the pathway to cell death in cancer cells or any cell, apoptosis, but particularly in homologous recombination deficiencies. And I will go over a little bit more in detail, but really what that means. It's a large family. It actually has 18 Parp members. There's Parp 1 that a lot of people know about mostly, but there's many other factors of Parp. And again, this homologous recombination deficiency, you've probably heard about that a little bit. It's one gynecologist recently I heard talk about this is it's actually a state that these cells can be in that actually can help Parp inhibitors work. And BRCA is really one of the best known HRD deficient pathways that we can look at.
And Dr. Bigsby, I guess I would just say, as your layperson advisor, I don't know that people have heard of HRD, and I wouldn't even make an assumption on BRCA either.
Excellent. So we'll go through those definitions here in a minute. So that's good. So we'll go in there because this is, you see all these BER, NER on this slide, SSR, HR. I mean, all these terms give us the ability to make decisions in Parp. So it's not an easy decision in giving a Parp. It's not just, hey, you got ovarian cancer, let's give you a Parp inhibitor because you have ovarian cancer. A lot really goes into it. So Parp enzyme plays roles again in repairing DNA damaged through the NER and BER. Those are the main areas that Parp enzymes play a role in, but there's other pathways of DNA repair, as you can see here. These are again where Parp is, or single-stranded break repair, and this goes way back into just general genetics and how they repair. All our DNA goes through changes that need to be repaired, and these are just the ways they do it. So how do they work? So single-stranded break. So what breaks DNA? It can be, the most common thing that people refer to when you read books or they talk about it is like radiation. Radiation can damage the DNA, but other factors and environmental factors and genetic factors can do that. So single-stranded DNA breaks occur frequently in proliferating cells. Well, what is a proliferating cell? Well, cancer cell's proliferating cell. It wants to divide and grow and spread. And so repair of these cells are essential for survival of the cell. So what we don't want in cancer cells, we don't want those cancer cells to survive once they've had these breaks. And so this is actually how the Parp inhibitors work. So Parp inhibitors inhibit the Parp enzymes and thus the repair. I'm trying to, I can't see part of my slides here because of all the pictures. I don't know. Let me see if I can shrink this. Just trying to, yeah, I can't do that. So that's all right. So let me go back here. So Parp inhibitors inhibit the Parp enzymes and thus repair the single-stranded breaks by the BER. And so this is the Parp inhibitors are more in this BER pathway. And then these are converted to DSB as double-stranded breaks. So if you think of those, if you've seen the DNA, those little helix, the single strand is one side or the other side, and the double strand is where you see both breaks. And so most DNA, when they break, they don't break right across from each other. There's almost a break on one side of the single strand and break on the other side of the single-stranded DNA. So the single-stranded DNAs, single-stranded breaks are converted to the double-stranded breaks and that are toxic to the cell. So there's now HRP, so human recombinant, and what that really is, HRP, is these pathways actually work okay. They can repair the double-stranded breaks originating from single-stranded breaks. The HRD cannot repair these, and this is where the BRCA comes in. So HRP is HR proficient, or human recombinant proficient, and HRD is deficient. And we're going to go even more into these here in a second. So BRCA 1 and 2. So here's where we come to some of the terminology. And all this has factors in how we utilize BRCA, or utilize Parp inhibitors. So BRCA 1 and 2 are the most common genetic mutation that we've really utilized Parps in. In fact, they were really the first approval of the Parp inhibitors in BRC, and those really with ovarian cancer. And usually we've seen breast cancer take the lead on so many things in treatment. It's just taken the lead, it's taken the research lead, it gets a lot of funding of research. But now breast cancer is actually following us from a Parp inhibitor standpoint, and we were really first to market and really looking at these in BRCA patients. So BRCA1 and 2, we all have BRCA1 and 2, okay? I have BRCA1 and 2, everybody has, you don't have to have ovarian cancer to have BRCA1 and 2. We all have these genes, but when it's mutated or damaged, that's when this puts a patient at risk for cancer. And in BRCA1 and 2, that's breast and ovarian cancer primarily. So HRD is a pathway that cannot repair damaged DNA as well. So it's a similar pathway, and BRCA1 and 2 is just part of how those work. The HRP means they can repair the damaged cells. So those cells work okay. They can do things on their own. So a Parp inhibitor wouldn't particularly work in something that it was already working. So then there's BRCA wild type. So this is always confusing about what is a BRCA wild type patient. And it's kind of a little bit of a misnomer. It's really the patients that do not have germline, and sorry, I have two little kids as I do some of these projects, it's germline there, or somatic. So what germline mean, which are the lines below that, germline is the BRCA mutation is inherited. It's found in every cell. Okay, so that's why we can draw your blood, you can spit in a cup, and we can know if you're BRCA. If you're somatic, when you draw your blood or spit in a cup, you're just going to have normal BRCA genes. Again, we all have them. And so a somatic mutation is where we see that BRCA abnormality in the tumor. So we actually have to test the tumor to be able to find out if they have these BRCA like abnormalities. And then there is loss of heterogeneity. So that is essentially similar to the HRD. It's just a different way to test for that. Again, it is a problem. It detects a problem in the pathway similar to HRD. And some other companies, such as foundations, really test for this when they're actually testing for the HRD area. And we'll go over that in a second. The next generation sequencing is really how we just test these genes. And this is just the newest way we test the genes. And then MDS, myelodysplastic syndrome, is something that the Parp inhibitor can cause. It's actually a malfunction in your cells. You may not be able to make white cells, platelets, red cells. And so this is a risk, although low in Parp inhibitors, it is a risk, which if you get MDS, it can be more difficult to treat you in the future. And so this is something we don't typically want to see. So how do we do HR testing? An old way to talk about is a SCAR test if you look some of these things up and research them. But My Choice HRD, which is a Myriad Genetics, they do this. A lot of the studies were surrounded by My Choice HRD. This is how they arrived if patients are at HRD positive. They looked at several different things to really come up with this score. And then there's the LOH test, which is a similar test for HRD as we talked about before, which really tells if you fall into this state, as I said before. And really this state would suggest that you would be more susceptible to the PARPs working than somebody who already has cells that work, which are the HRP or HR proficient.
Hey, Dr. Bigsby, can I ask a quick question?
Yes.
So then basically for, if you're a newcomer to this language, the bottom line is that PARPs further interrupt cancer cell from fixing itself.
Exactly. And,
okay, and that's what
and essentially there's a couple of different ways. It's all the HRD pathways because BRCA is just part of that, and this LOH can detect that in patients that aren't BRCA. And then we have that subset of patients that have cells that actually already do it efficiently, and those actually is where PARPs actually don't work. because they already have the mechanism to do that. It may not be able to actually do what it's supposed to, and eventually PARPs will or can stop working as well. And we'll talk about a little bit of that in a minute. So did that clarify that?
Yeah, thanks. I mean, I guess I just wanted to boil it down to, it's really about keeping not letting it fix itself.
Right. So the cancer cell can't fix itself, it dies. And that's what we ultimately want, is these cancer cells not to survive so that the patient survives. So there's many studies, and this isn't all of them. This is just a hodgepodge of different studies. There's many other studies out there. These are some of the main studies that you might have heard of in studying. This is both in the recurrent setting, recurrent ovarian cancer, and both in the upfront setting as treating with PARP right away during your first lines of treatment. And we're going to go over the main ones that really are what we call upfront treatment, or treating early on and not when your cancer comes back, but let's treat you up front. And we'll help you understand why we're really headed in that direction because we've had some really good success in our studies. So indications of PARP inhibitors, and we're not going to really look at one PARP inhibitor over the other or anything like that. You can ask me some of those questions, in the future, and I'm not here to really, change your mind on things or have your physician, think, well, maybe I should be doing this or that. Really, what I'm here to inform you is that really to give you a better understanding, and so that your discussion with your physician is much more applicable. You can understand it a little better as to why he or she are choosing what they want to do. So maintenance in upfront treatment. So really what that means, maintenance is after you finish your chemotherapy. Everybody still gets chemotherapy in the setting of ovarian cancer, but maintenance is taking one of these drugs after you've completed the chemotherapy. And then there's one study that I'll go over where we actually utilized the PARP inhibitor during chemotherapy and then continuing the PARP afterwards. And that's actually a drug that's actually not approved. It's one of the other PARP inhibitors that still continues to be studied. So upfront treatment, let's go over the study. So one of the biggest studies that are out there is called SOLO-1, and all these studies have these letters associated with them, and they're all different companies that do that. And so the SOLO-1 trial was really one of the biggest trials that we just said, wow, as clinicians, that these PARPs work. When we were treating in recurrent setting, we were seeing good results with the PARP inhibitor. But when we first started using PARP inhibitors, you had to recur over 3 times before we even gave you a PARP inhibitor, from an indication. Now, you could have gotten a PARP inhibitor on a study, but we were treating in the recurrent setting, and we were seeing some good results. But this SOLO-1 was really the wow factor. And so this was olaparib following platinum-based chemotherapy. So everybody got their chemotherapy. These were all BRCA patients. So either you had the germline, as we talked about before, which is patients that have the abnormality in all their cells, or you were somatic, where you just had it in the tumor. So those are the only people that could take this medication in this particular study. And it was a phase 3 trial versus you got the drug or you didn't get the drug. So that's called placebo. So if you look at this particular study, it's fantastic. And what I want to talk about, there's a lot of study things. There's all sorts of terminology in studies. But the only one I'm going to really talk about today is that of a hazard ratio, okay? And that's what this HR means right here, hazard ratio. So if you have a hazard ratio of 1 when you're comparing 2 things, okay, that means they're the same, okay? 1 really didn't do anything better, okay? When it's less than 1, okay, that means the thing you're studying did better than what the other thing you were studying. So this, if you look at the placebo versus that of the medication, if you just subtract 1 minus 0.3, you get 0.7, right? So that means this had a 70% reduction in progression or death when you took this medication. So that's huge. We haven't seen these hazard ratios in a long time this pronounced, and we'll go over some other studies as well, but this was huge. And so these, at 3 years, many of these patients were still alive, okay? And this was just reported last month that at 5 years, if you had BRCA and you were on the drug, okay, that 48, almost 50% of people are still alive at 5 years. So this was remarkable. And so this was actually just reported last month in an update. They gave the 3 years a while back. And if you look at the placebo, which means you just got chemotherapy and some fake pills, you didn't know whether you were on the drug or not on the drug. Now, a lot of people, when we're doing studies, can sometimes predict it because they read about Parp inhibitors and they're like, I don't have any of those symptoms, so maybe I'm on placebo. But I have a fair amount of patients that actually don't have a lot of side effects even on the Parp inhibitor. And we'll go over side effects in a little bit. But if you look at 5 years in the placebo group, there is only 20% of people alive at 5 years. So drastic difference from 50 to 20% really. And so it has been remarkable. And so 56 months is just huge where we don't see progression of disease. And if you look at the placebo group, it's 13.8 months for that number. So pretty remarkable, and this was really the wow factor for us for Parp inhibitors. But we continue to be wowed. So here's the Prima Study, which is niraparib, which is just a different Parp inhibitor, different company. And this was also a phase 3 trial. Let me just tell you a little bit about phase 3 trials. Phase 3 trials is really, we know the dosages, we know it works in patients. We just want to do this on a big scale and really see how these work. That's just the basic explanation of a phase 3 trial. These are also newly diagnosed, so this is new diagnosis. You went through your chemotherapy and then you received this in a maintenance fashion. And you had to have a complete or partial response to chemotherapy. Most people have responses to their initial chemotherapy. It's just how long they last. In this particular study, they excluded these stage 3 patients with no residual disease after cytoreductive surgery. So if you went through your surgery and you didn't have any cancer after that, you weren't eligible to be on this medication. And so this is where I think part of that is we see the difference in the hazard ratio. And I'm going to talk about problems with all these studies. One of the problems with all these studies and what we're doing now with them is this kind of, we started to do cross-trial comparison. So you could look at this HR hazard ratio. It's not as good, okay? So the lower that, 0.3 is better than 0.43, right? But they also excluded these other patients there, and that may have been a little bit of a difference, but we don't particularly know, okay? So this was a different population, okay? This population was all comers. These weren't just the BRCA patients or the germline or somatic. This was everybody. And we'll go over how that really works. So there was a couple of different dosings that when we're looking at olaparib, they all had the same dose when they went on this study. They differentiated the dosages in niraparib just because if you didn't weigh that much, which means less than 77 kilos, or your platelets are less than 150,000, we knew that you had a higher risk of adverse events. And so they just adjusted that. So if you were less than 77 kilograms or you were less than 150,000 platelets, you got 200 milligrams daily. All the other patients got 300 milligrams daily. So this was a 36-month treatment. Okay, the last treatment was a 24-month treatment as well. So this is why I caution on this cross comparison and things. You can't really compare these studies face to face, even if you take out these patients. Okay, so if you look at this line down here, where it says HRD BRCA mutation, these are the ones in the last study. Okay, so this did have a lower hazard ratio, not as certainly low as the last one. But again, now we're looking at a smaller population and not as big of a population as well. So we have to take all these factors in. We really can't cross compare these. But if you see that the best patients in this trial were actually the patients with the BRCA somatic or germline mutation. That's what this means, okay? These are the essentially wild type. So these people are HRD positive, okay? But they don't have the BRCA mutation in the tumor or in their blood cells. So as you can see, they were 0.5. So again, they didn't do as well. Again, the lower the number, the better. You take 1 minus this number and you get that. So this has only had a 50% reduction. This had a 60% reduction. And if you look at HRP, okay, these patients don't have any deficiency in that pathway, which is how PARPs work. So the PARPs typically don't work as well, although we do see, this is less than 1. So it's not the same, but we do see improvement in even those patients. So PARPs likely work because of the PARP, again, we talked about those 18 different complexes and things. PARP probably have some different actions within these pathways that probably help in these patients to a certain extent. So let's move on to the next trial. And so the next trial is a little bit different. So this is, again, olaparib. And it was again for 24 months. But in this particular scenario, there's a new drug that's entered into the study, and that's Avastin, which we've used in this ovarian cancer treatments for many years. And so in this particular population, you had to have at least, when you're getting your chemotherapy up front, right, you had to have at least 3 cycles of Avastin in this study. Okay, and so that is an actual factor, and we'll talk a little bit about that in a second. And so after your chemotherapy and at least 3 of those having Avastin, then you went on to 24 months of the olaparib, which is 300 milligrams twice a day. And so this, again, is a different study population. So these are all HRD positive patients. So you could be BRCA. So BRCA patients have an abnormality of that pathway. Somatic patients, germline, or somatic patients also, but also those patients that are just HRD positive. So you have an abnormality of that pathway. Again, this is a state that you're in. And so these HRD positive patients, all it really excluded is those HRP patients, the ones that are already have mechanisms to repair. So again, a different population. So when you look again at this hazard ratio, you say, oh gosh, this hazard ratio continues to go up. Let's go back to the first study. But again, these are different populations. And so when you look at this, the progression-free survival, how long did this cancer stay away? It was 22 months versus 16 months in the placebo. So the other group was placebo. They had Avastin, but they didn't have the PARP inhibitor. But if you actually go down and actually look at these, so these are the germline, okay, and the somatic patients. So those people that have an abnormality either in every cell of their body or the mutations, that's getting pretty near that first study that we looked at. And again, these are different populations, different numbers. And so we have to look at that. So if you look at the HRD positive, but BRCA wild type, meaning they don't have the somatic, they don't have the germline, they still did fantastic from that standpoint, that low number there. Now the HRP patients certainly didn't do as well. That's only an 8% reduction. And so, sorry about that. So there was an interim analysis as well, and And one of the findings, we always look back at these particular studies. One of these findings is that this cancer stayed away in patients that had upfront surgery and not chemo first. So talk about that. NAC means neoadjuvant chemotherapy, and PDS is primary debulking surgery. So what they found when they looked back at this is that people that got a little bit of chemotherapy first and then surgery and then their finishing of their chemotherapy, those patients didn't have their cancer stay away as long in this particular study, whereas the primary debulking surgery patients did better. Now, this is just a finding, again, an interim analysis where we scratch our head and we make new studies from all these things we learn from these studies so that we can better our survival really in everybody. But that was an interesting finding from that standpoint. So let's go on to the next. And this is a trial. This drug Verapamil is not available in the United States at this point in time. But this is a study where we actually, and it probably will be available in the future. Some of the studies were done here in the United States actually for this drug. And some of you may have been on this drug who've been on any research protocols. But what this particular study, and some of you may have been on this research study from that standpoint, but what this study was is we actually used the PARP up front. So while you were on chemotherapy, you got a PARP inhibitor as well. And this study actually had 3 arms. One was you had chemotherapy, you had the PARP inhibitor, and then you'd continue the PARP inhibitor afterwards, okay, for 30 cycles of that, or 30 months essentially. So there was another arm where you had the PARP inhibitor with the chemo, and then you didn't have anything after that. You had placebo. So what we were seeing is if we just give a little bit of PARP up front with your chemotherapy, would that help you long term? And we found that actually wasn't true. That actually was the worst group. And then the third arm was actually just chemo. So all you did was chemo, and then you got placebo after that. You didn't get a PARP inhibitor after that. And so if you look at these, again, you're looking at these hazard ratios. Overall hazard ratio in this was 0.68. But if you looked again at these BRCA mutated, meaning you had a somatic in the tumor or in all your cells, the germline, then you had a pretty good, you know, when you're getting down to that 0.3, 0.4, did extremely well. And then these didn't do as well with that. So now you're kind of getting the gist of this is that certainly we see when you have the BRCA mutation, whether it's in your blood and all cells of your body or it's in your tumor, you certainly do better with PARP inhibitors. And why that is it's correcting the defect that's there. And so that's why it improves that. And so you see difference in response, again, progression-free survival. If you were in the group that had the drug and then continued the drug, you had almost 35 months without cancer versus 22 months when you just had chemotherapy. And that's in those BRCA patients again, and then just the HRD population. So if you just had the HRD, so you didn't have the germline or the somatic, you still had, 31.9 months from that standpoint. So if you look at HRP, so that means your cells already have the mechanisms to do that. They just don't work very well. And these are the patients that didn't do as well. So you had a question?
Yeah, I was just curious about, let's say you don't have, your tumor did not have any HRD. Is that something that can develop over time, change over time as your cancer progresses? Do people?
It can, and that's the next thing I'm going to talk about a little bit, is that the best time to really test for this deficiency is early on, because of the changes that can actually happen in these pathways. And so that's the absolute best time to actually be able to do that. The second thing I want to say about this is that these HRD studies, or the LOH that we talked about, they're not, they aren't great, okay? So when we've looked back at these, a lot, if we really look into this HRD testing, some patients don't do as well, and why is that? Well, if you look back at this slide, I'll go back here a little bit, and we'll look at this slide here. So they've come up with these numbers. You know, this my choice HRD is this greater than or equal to 42. That's just in looking at these studies where they feel the number break off is that you benefit from that. Some of these studies have just looked back at response to treatment to know where the cutoff is. So they go back and they look at the study and say, oh, these patients have a little bit more response. This is where our cutoff is going to be. And so these aren't the perfect tests. So if you're HRD positive and you don't have BRCA in your tumor or all your cells, that testing is little gray, and we still have some work to do in that testing. And so that's something really to know, that's not all what it's cracked up to be. Now, it is, you know, I talked about being on these advisory committees. Some of the doctors across the United States won't do HRD testing, partially because the test is not that good. Partially is if you look at the Prima trial here, is that everybody could go on a Parp inhibitor, so why should I, you know, get HRD testing? So this is some of the things that people think about. Others then think of, well, I want the HRD testing. Why? Because then I could counsel you that you have a better chance of this working. So we want to let you know as, hey, you're falling in this group, not this other group. We want you to fall in this, say, just looking at this Prima trial, we want you to have twice as much time without cancer than another patient. So there's a lot of different ways to look at this. So in conclusion of just this upfront Parp, you know, I just went over these 4 large trials, all showing improvement in survival from a progression-free standpoint. Now, what that means is that your cancer is just staying away longer, is really the quick summary for that. And so Parp should be in upfront treatment for most, but not maybe all. So if you look at niraparib, which is approved in upfront in all patients, if you look at the patients that are HRP, which again means that Parp really doesn't have a direct effect on these patients. It probably does have an indirect effect because we do still see some improvement in those patients, but it's not as vast. And so some docs across the country will want to potentially save Parps in those HRP patients for maybe another time, or maybe we have some new studies coming up to where maybe a Parp plus another medication might help in those particular patients. That's something we just don't know. And for somebody to take, say, 3 years of this medication that has a fair amount of side effects for a small, talking less than 6 months advantage, then is that, with all the toxicity it can create, is that beneficial? Or can we wait in the future to actually utilize these drugs in a different manner and not create a lot of that toxicity? The other thing is that and I'll talk about this in a minute, is resistance. So some of you may have heard of platinum resistance, and that really tells us really how long a patient's going to live. If you have platinum sensitive, meaning you've really responded to the platinum chemotherapy or your upfront therapy, you likely are going to live longer. And so BRCA patients are known, you know, for that. So if you're BRCA genetic mutation, you tend to respond better to chemotherapy. But there is a resistance that can be up front or can even develop in that platinum. And now we're seeing that in PARP inhibitors, and there's many different mechanisms for that. And so we have to tease through that as to how we utilize these PARP inhibitors so that we don't cause more harm than good in the future, and knowing completely about these medications and things. So some limitations is that really we have one study that recently came out with some overall survival data, which is what OS means. But really we don't know overall survival. So in all these studies, we've improved progression-free survival, meaning the patients are keeping their cancer away for longer. But are they going to survive longer? That we don't know. And so we really need more studies. We need these studies that we have now to mature. Are we going to have more cures? We certainly think we do, especially in the SOLO 1 trial where we're getting 56 months without cancer. That's phenomenal. But what happens when it does fail? If it fails at 58 months or 60 months or 65 months? So we really need some overall survival data in the future. Another limitation is, like I talked about before, there's a lot of this cross-trial comparison. We're comparing a lot of these trials, and we really can't do that. We have to take the subsets of how we studied that, and if particular patients fall into that, then utilize it in that way. And then other factors are, we've talked here at COCA, many times about cost, and we're going to talk about toxicity here in a few minutes. But the financial toxicity of these drugs, they're not cheap. The response and the different responses that we're getting in these, the different characteristics of disease. Everybody has a different cancer. You can have a high-grade serous ovarian cancer, but they all act differently. They're all genetically made up differently. They all respond differently. And so we have to take that into account as well. And then patient factors, patient preferences, when we go over these medications, these side effects, your CA-125, how it responds, other tumor factors that we get from some of these studies of the tumors. We have to take that all into consideration. So there's 3 drugs essentially approved for recurrence. We're not going to really go there too much today. They all show efficacy. And so it's been a fantastic drug, but really as we're moving up front to PARP inhibitors up front, that we're going to talk less and less about recurrence, because one other thing that we don't have is what we call PARP on PARP treatments. So say you fail a PARP inhibitor and you go on to another drug or something in your treatment. If we give that PARP back or even a different PARP, does it work? Is it going to work again? We don't know that. We do not have enough information on treatments of utilizing PARPs again in treatment. And so that's more to come. Because so much PARP is being utilized, we're going to get that information. But we don't have a lot of information on treating PARP after PARP. So again, other concerns, we talked about resistance, and we're finding many pathways in developing resistance. And so we need to look at, how we're going to tackle that, and what are we going to do with PARP resistance. And so down to side effects. These are, everybody, as I've practiced for years, has always wondered, hey, don't you have a pill for this? And now we do. Because a lot of times people think pills are something that doesn't have as much of a side effect. Well, unfortunately they do. And so these PARP inhibitors all have these side effects, anemia being very common, thrombocytopenia being less common. That's platelets. That's if your platelets go low. Fatigue is very, very common, one of the most common. Nausea is very, very common, one of the most common. Vomiting can happen, not as common, but nausea being the biggest there. Diarrhea, constipation, and again, this myelodysplastic syndrome where your cells now don't function, or essentially you can't make the cells, your platelets, your white blood cells, your red blood cells. And so that can be a factor in treating you with chemotherapy and treatments in the future. So some specific side effects of specific agents. Olaparib can cause pneumonitis. It's very rare, but it can have some pulmonary issues. It can elevate your serum creatinine. Typically that isn't harmful. That's something we typically watch. Occasionally we have to stop the medication or reduce the medication. Rucaparib can elevate your liver enzymes. Please put an eye in liver there. Again, trying to prepare this with two little 3 and a 1-year-old running around. Elevation of cholesterol, and it can also elevate the serum creatinine. And then niraparib can have a little bit of issues with hypertension, hypertensive crisis, headaches, and it has a little more susceptibility to the platelets, so causing lower platelet counts, and that's why the dose adjustment. Treatment of toxicities, there's medications. A lot of times we will, especially the nausea medications in the GI, we will prescribe medications for that initially, but exercise can help. And many other things. People have done multiple different just activities, whether it's even acupuncture and things that have sometimes helped these as well. One of the common things we did in the studies is what's called dose interruption. That means just stopping the medication for a time to see if the symptom we're trying to resolve actually goes away, whether it's anemia, whether it's nausea, constipation, or whatever. And then oftentimes we'll restart at the same dose. Sometimes we'll decrease the dose and introduce a new dosage. And so that's where dose modifications or reductions come in. Or discontinuation of the drug. Now that was rare in almost all the studies that we've talked about, and even in the recurrent setting. It really runs around 11 to 13% of patients in these studies actually stop the medication because of side effects. So it's actually pretty low for as many side effects as it causes. So these are just the dose reductions that we use in the different drugs. The starting dose, the first dose reduction, second, and in rucaparib, there's a third dose reduction for that particular medication. So preventing and treating side effects, you know, we need to anticipate these toxicities. We know they're going to happen in patients, so we really need to educate the patients that are going to go on the Parp inhibitor so you're aware of what's going to happen. When you do have your blood counts be problematic, with most commonly being anemia, you have to wait for the blood counts to recover from your primary chemotherapy. That can help us not have as many problems as you go into your Parp inhibitor treatment. So select a Parp inhibitor based on expected tolerability. Again, there's some different side effects that we talked about in the different drugs. And so if you say have some chronic lung disease that may be a problem, maybe olaparib isn't the drug for you, maybe one of the other drugs that doesn't cause the pneumonitis. Or maybe your platelets were a problem during your primary chemotherapy, and so maybe we wouldn't use niraparib just because it does have some platelet problems as well. And so docs think about these different things as we choose these medications. It's the study, but also the patient. So use prophylactic antiemetics, that means anti-nausea medications, but we typically can wean those over time. You can actually go off of those. So actively monitor your blood levels during the treatment. Each drug has a different protocol as to how much we follow, and usually that slows up over time. And really to know that these medications, essentially the majority of the side effects are in the first 4 to 6 weeks, and those are the hardest time, but most side effects improve. So these guidelines, ASCO has guidelines for testing, and a lot of this we went over, but this show will be available for you to relook at, so you can look through those, because I want to have some time for questions. And so that's just the testing, what the American Society of Clinical Oncology suggests for guidelines and testing. And just some suggestions on Parp and treatment. And what I always caution people is these are guidelines, these aren't rules, because there's so much difference in patients and tumors and cancer and things that there is not one rule in the treatment of ovarian cancer. And so we want to take that into consideration. And so in conclusion, Parp inhibitors are excellent advances in ovarian cancer and treatment, but we still have a lot to learn in these treatments.
Wow.
that was educational for you, and you learned, it was a lot of information in what, less than an hour. I mean, these advisory boards that I sit on are sometimes 4 hours. We talk about this stuff. So we did all this in about 50 minutes. So there's a lot to it. And some of you may still be a little bit confused on all the terminology and everything. But don't hesitate to ask questions to your physician. I'd be happy to answer questions as well.
Okay, and I think, thank you so much, Dr. Bigsby. It is kind of mind-blowing what all this terminology. So we do have some questions.
Sure.
And we still have over 50 people on this call. So I guess I'm going to ask that people submit their questions through chat, because I think it'd be too difficult to unmute everybody and manage that. So I will go ahead and read from the chat questions, and feel free to submit from there. So our first question, when you were talking about cells that proliferate for PARPs being effective with them, there was a question as, does proliferation rate matter in effectiveness of a PARP? Higher rate equals greater success, question mark?
Well, certainly with chemotherapy, because chemotherapy, and when you look at chemotherapy and how it works, it is killing rapidly growing cells. That's why people lose their hair with Taxol and things like that. It's a cytotoxic agent. As far as PARP, it's working on the individual cells. So really, from that standpoint, the amount of proliferation, how aggressive this tumor, all these high-grade ovarian cancers are aggressive just in general. And so it's just proliferation, meaning a cancer cell is growing and spreading, right? But it's not necessarily a amount of proliferation. Although I can say that low-grade serous ovarian cancers, we haven't really seen any response to Parp inhibitors.
Okay.
Which are typically slower growing, but we think that's a different apple, that high-grade ovarian cancers and low-grade ovarian cancers are really two different cancers. Even though we call them serous ovarian cancers, they clearly act differently.
So I've got a question from my new good friend, Marge Karras. And her question is, how do you feel about the NCCN guidelines recommendation for HRP patients who had Avastin receive the combo of Lynparza plus Avastin despite the low hazard ratio in Paola?
So what's that again? Say that again.
How do you feel about the NCCN guidelines recommendation for the HRP patients who had Avastin receive the combo of Lynparza plus Avastin despite the low hazard ratio in the study Paola?
I would say that I wouldn't particularly combine. I think in those patients, we need to be really cautious and not use all our guns up front. And so I would be very cautious in those particular patients because of the low hazard ratio. And a lot of my colleagues around the country will do the same. I just saw a little note from Keon, who I think is on somewhere. I don't see his face or anything, but you know that they had hey, there it is, the PARP on PARP studies. There are some studies coming out, but we don't have a ton of studies. We have seen that, but I think it's to be cautious. And the other thing that I think we have to be cautious about with PARP on PARP is MDS. And really, you know, does that in a large population, does that percentage start to increase? Because typically it's less than 2%. So it's very low in patients, but is that going to increase? You know, can side effects particularly increase? I think we need some bigger populations, but you made a good point. There are some studies out there that PARP on PARP can work, but it just needs to be cautious from that standpoint.
Yeah, I just want to jump in about the rationale for supporting Paola PARP and BEV approach through NCCN. I was actually part of the opinion that wrote that. When you look at the contrasting studies of GOG 218, which just used bevacizumab, and then Paola had a higher risk patient group than GOG 218, but did just as well or better. And when you superimpose those curves, and you just said not to superimpose those curves, but here's the scoop. This is a worse prognosis population at which the addition of the PARP inhibitor to the BEV made the curve even better than the addition of the BEV by itself. So again, as the patient, looking at you saying, I don't want this to ever come back, I'm likely to add the PARP, especially if they're germline BRCA mutant.
So, well, definitely if germline, mutation, but are those patients that are HRP, from that standpoint, I think that, these patients have a higher risk of, having recurrence. And then what do we do with these patients afterwards? We may get a small increase in progression-free survival, but as I talked about before, are we really benefiting overall survival? And we really helped them, or we have just created toxicity? And these are I love Keon being on, because these are the great discussions we have on these advisory boards, as well as like, it is a lot of information to encompass. He makes a good point. This was a higher risk population of those in GOG 218, or even ICON 7 is another study with Avastin as well, that we look at. And so this is just like the advisory, where I probably in a proficient patient would not utilize a PARP. I may use Avastin alone. But this also goes back way back as to what was their response to their initial treatment. Did they have a fast decreasing C125? Did they have a slow decreasing C125? How much disease did they have initially? What was the findings of their surgery? Were they optimally debulked? So there's a lot of factors that go into individualized care. And I tried to take a look at the whole picture.
And Dr. Babak, if you're still on, just because you answered in part, if both of you docs could answer how much of a change in creatinine usually provokes a PARP holiday or dose reduction? I don't even know if I said that correctly. Do you understand what I'm saying? Creatinine? Is that?
Creatinine. Yeah, so this isn't very common, actually. In reality, I've only had one patient where I actually dose interrupted. And then I started at a lower dose. Her creatinine went right around near 2. Normal creatinine's around less than 1, less than 1.1. Most of the time I just watched that, and most of the time it has trended down. So I haven't seen a ton of that from a creatinine standpoint actually cause a major problem. What we also have to think about in these patients is that creatinine rising for another reason. Is their tumor progressing? Are their kidneys malfunctioning from that standpoint as well? So we have to be cautious about just saying, hey, the creatinine's from the PARP inhibitor, and knowing that other things in ovarian cancer can cause the creatinine to rise.
Dr. Babak, did you want to, what you wrote into the chat, do you want to share?
Yeah, I agree with Glenn. I've rarely had to dose reduce for creatinine. I think one patient is about my N also.
Okay. Great. Here's a question that says, I am currently on Avastin and Lynparza. Do you know of extreme painful headaches due to the medication? Is that a side effect you've encountered?
So Avastin certainly can cause headaches. That we've seen fairly commonly. Niraparib has a little bit more headaches than the other medications as far as the PARP inhibitors. So if you're on olaparib and Avastin, then it may not be the PARP, although headache is a potential for olaparib. It's just seen more often in niraparib.
Okay.
Yeah, I agree totally. The bevacizumab has known side effects, of which hypertension and headaches is a known one, less so with the PARP inhibitors.
Has there been documentation of sensitivity to heat to extremities, unbearable itch and extreme ties, hot tub, sauna, etc. Been on niraparib for 3 years. Have no other known side effects.
I've not personally seen that. Have you seen that, Keon?
I have not also. That is, that's something to take note of. I have not seen it.
Okay. Is there any data regarding for PARP in mucinous ovarian carcinoma?
Actually, most of the PARP studies are that of either endometrioid ovarian cancer or high-grade serous ovarian cancer. And we really look at different pathways of genetics in those mucinous tumors. That's mismatch repair and things like that. So it is mucinous tumors, it's not commonly in a lot of these studies. Most of these studies have kept out mucinous tumors.
Yeah, I think Paula allowed them if they were germline or tumor HRD positive, non-high-grade serous. So a handful have been included in studies, but it's very rare for them to be HRD positive or germline positive.
Here's a question from Lisa that says, the olaparib study was 24 months. Is there any support for stopping before 24 months to reduce side effects?
So I mean, the literature is the 24 months, and if you had a complete response, you certainly stopped it, at 2 years. But there's nothing to say how long these. I think that's another thing that we're trying to figure out. Niraparib's 36 months, olaparib's been that of 24 months. We just don't have any good data if you take it. I mean, if you look at the Velia trial where they just used the PARP with chemotherapy only, which is about the shortest course, it didn't do well.
Okay, well, we are over our hour, and I don't see any new questions in the queue right now. So I'm just going to take this moment to say thank you so much, Dr. Bigsby and
Thanks,
Dr.
Keon,
Babak, for jumping in. And we really appreciate you sharing your expertise with this group online. Sure appreciate it. It's a lot to process. And everybody, I guess I want to say, if you are taking a PARP or want to take a PARP and you are worried about the cost, each of the companies has pretty good programs, and our Carol's Wish program can absolutely help you get signed up for copay assistance. Also, if you're suffering from any other financial stress because of treatment, please feel free to call us, look up Carol's Wish online, and we can help. We've really been able to help a lot of folks tackle some of these costs. So feel free to contact us. And thank you, Dr. Bigsby. Look forward to seeing you soon. We'll make this available online, everybody. Feel free to
take care. Thanks for coming, everybody.